So we want to understand radiobiological equivalents of treatment schemes, including combined external beam radiation therapy, EBRT, and HDR brachytherapy, high dose rate brachytherapy, as well as high dose rate brachytherapy fractionation. We want to be able to calculate Eqd2 equivalent dose in 2 gray per fraction for the target and organs at risk to determine overall treatment effects, and appreciate prescriptions and dose limits based on international recommendations, and recognize the effect of treatment delays in radiation therapy. That last one is sort of, it's an important one that a lot of people don't really pay maybe enough attention to, and it's relevant in both external beam and brachytherapy. We'll get to that at the end of the lecture. So before I get into too much, I think the most important thing to think about as we're talking today is just this therapeutic window and tumor control probability and normal tissue complication probability. That's what radiation therapy is all about, right? We want to, so here's the blue or purple curve here is the tumor control probability. So we want to be somewhere up here, right? We want to be closer to 100% of tumor control. And with the normal tissue, we want to be way down here. We don't want a normal tissue complications probability to be very high. And so if we put on a line of dose, let's just say it's whatever this dose is, and this would give a tumor control probability of whatever that is, about 85%, and a normal tissue complication probability of about 20% or so. If we could move this normal tissue complication line this way, and if we can move the therapeutic ratio, move the tumor control probability to the left, now all of a sudden we've got a better chance at curing the tumor and a less chance of normal tissue complications. So that's what this is all about, and that's really why we're getting into fractionation schemes, dose per fraction, the length of the treatment time, missing fractionation, and why we end up wanting to compare everything in equivalent doses in 2 gray per fraction. But just keep this in mind. This is what it's all about. So Radiobiology Refresher. We'll have a number of slides over this, and we'll go over the number of methods that cells actually die and why some are more radiosensitive than others. So how do we kill cancer cells with radiation? There's direct and indirect damage. There's DNA damage. So you can have double-strand breaks or single-strand breaks. There's damage to other organelles, such as mitochondria. So if you damage an important organelle within the cell could die as well. Subtle changes at a molecular level may have impactful changes at a macroscopic level. Complete and incomplete repair of permanent cell cycle arrest. And so let's talk about direct and indirect damage. So you've got ionizing radiation, and so you've got photons that come in, and typically, if you think just like dose, if you think about the delivery of dose to tissue, most of that dose comes from ionized electrons, right? So photons come in, they ionize and energize electrons, and those are what causes the dose and all the damage to tissues. All right, so this is what we're really talking about. So we've got photons that come in, they're ionizing electrons, and those electrons are then creating damage to the cell. And that damage comes in 2 different ways, direct damage or indirect damage. So those ionized electrons, energetic electrons, can have direct contact with the DNA of the nucleus of a cell. And it could break one of the bonds. And if you've got enough radiation and enough energized electrons that are coming through, you could have a double-strand break. So that means the 2 strands of the DNA broken at approximately the same level. So you can see that you would have an increased probability of this double-strand break, 2 breaks happening in the same place, if you've got more energized electrons coming through. That means more radiation. That means more dose. So more dose means more double-strand breaks. Less dose, less probability of double-strand, so it's more probable of single-strand breaks with less dose. Then you've got indirect damage, and this is where actually the majority of problems for the cell come. And this is where the ionized electrons from the photons cause free radicals. And so these are just, an ionized electron inside of the cell that could be damaged. You got hydroxide, H2O2, in other free radicals. And these are just little molecules or free electrons that have the probability to interact with other molecules within the cell. And the method that they interact, they end up causing damage to the cell. And so if these free radicals float around in the cell and they end up interacting with the DNA, they be more probable with a higher percentage or a higher amount of these free radicals. And again, the higher amount of free radicals comes from a higher amount of dose. And this happens really quickly. So when we talk about just floating around the cell, it's happening at a fraction of a second, all of this. But that would be a method through indirect damage and directly ionized electron directly breaking a DNA single strand or double strand break. That was direct damage. So let's talk about the 5 R's of radiobiology. I'm sure a lot of you have already heard of this, and some of this may be a refresher, some of it may be new, but I think it's all really important information for ultimately understanding what's happening with radiobiology. So we got repair, that is the repair of cells between fractions, redistribution of cells into different phases of the cell cycle, repopulation of cells during the course of treatment, reoxygenation of cells during treatment, and radiosensitivity, the intrinsic radiosensitivity of the cell. And we'll go into each of these in a bit more detail. So it's difficult for a cell to deal with DNA damage. It does have the mechanisms to repair this DNA damage, but it takes some time. And if the cell continues to be bombarded with radiation, it won't be able to repair. So in between fractions, the cell has a possibility to repair. High dose rate treatments, HDR, or even high dose and external beam, assume no cell repair occurs during irradiation. So your typical HDR brachytherapy takes maybe 5 to 6 minutes for a new source. If you're using interstitial needles, it could take up to 10 or 11 minutes, but that's still a very small amount of time. And we're assuming that there's no repair happening during that time. Low dose rate brachytherapy, repair during irradiation can be significant and must be accounted for. So I've worked at a center and we had some issues with the import of a new source, and our source got less than 1/10 of the original air Kermas strength. And so we actually started accounting for the repair during the treatment. And so our treatments were not quite as potent as they would for a true high dose rate brachytherapy source. Okay, so let's talk a little bit about the repair mechanisms. So up here in the top right, you've got basically the cell and ionizing radiation causing direct and indirect DNA damage. So repair of DNA damage, you can have complete repair, and then the cell grows further, everyone's happy. You can have incomplete repair of the DNA damage, and this is where problems happen. So either the cell continues to grow and lives with incomplete repair of the DNA, and this then in turn could become cancer cell growth, right? Where you've got mutated cells that continue to grow and divide. Or with that incomplete repair, it can go to mitotic catastrophe. So when the cell tries to divide, but the DNA is partially broken, the cell dies during cell division. That's mitotic catastrophe. This is one major mechanism of radiation killing cells, both cancer cells and organ at risk cells. If you've got incomplete repair, another mechanism of cell death is apoptosis. And this is basically activation of cell death, programmed cell death for the cell. And this can take different amounts of time. It can take weeks up to months, even years, but the cell will eventually die even without having to divide. Or you could have permanent cell cycle arrest, where there's some DNA damage and the cell just goes into a sort of a resting state. So the impact of repair, and I've got some slides on some subsequent slides that will explain this a little bit better, but this shows a single dose, this red line, and this is a survival curve. So survival rate and dose on the x-axis. But if you fractionate it, the survival rate increases. So I'll show you some a little bit better pictures shortly to that in a little bit more detail. Repopulation. Each radiation fraction results in a decrease in the number of surviving clonogenic tumor cells. So clonogenic cells are the cells that have the ability to repopulate. Clonogenic cells that survive radiation can repopulate by increasing the rate of proliferation. So this is an important concept. So this typically occurs after 2 to 6 weeks after the start of radiation therapy. So right when you start radiation therapy, you're killing tumor cells, you're killing healthy cells, but what's important is the tumor doesn't start really repopulating at a high rate until a delay of about 2 to 6 weeks for different tumor types. And we'll get into this later as well. And so this is really important when we're talking about missing weeks of treatment. Again, just keep this in mind. We won't explain it now, but we'll get to it later. So heavy repopulation doesn't really start occurring until a little bit down the road after radiation therapy begins. If tumor can repopulate, increasing the overall treatment time will mean more clonogenic cells that need to be killed, need a higher dose to achieve later on in the presentation. Redistribution, basically the cell goes through different parts of the cell cycle from G1S, G2M, and we don't have to really know what all of these mean, but the idea is that different parts of the cell cycle are more radiosensitive. So fractionation helps with this. So for example, M, the mitotic stage, and G2, growth and preparation for mitosis, those two stages are the most radiosensitive. So if you deliver radiation to a tumor, more of the cells in the M and G2 stage are going to die, and fewer the G1 and S. But if you fractionate, so then if you deliver, you give it some time before the next fraction, the cells will redistribute themselves within the cell cycle. And so more cells will go to the M and the G2 stage. So when you deliver another fraction, more cells die. So this fractionation really helps with increasing the amount of tumor cells that are killed. Sensitivity to different cell cycles, again, just a picture showing that G2 and M stages are the most radiosensitive, and some of the other stages are less sensitive. And that's why that redistribution is so important. Get more and more, with more fractions, more cells going into the M and G2 stage. Reoxygenation. So oxygen assists in making radiation-induced damage to cells permanent. The more double-strand DNA breaks occur in oxygenated cells. Remember those free radicals that we were talking about? A lot of that had to do with oxygen and water. So oxygen creates more reactive oxygen species, these free radicals, for indirect cell damage. So if tumors are irradiated with a large single dose of irradiation, so before I get to that, let's just think tumor cells. So they're highly dividing, they're rapidly dividing, and they're just growing into a big bulk. So lots of times this big bulk of tumor cells does not have a lot of vasculature, right? So the normal vasculature from your healthy tissue can't really keep up with the tumor cells. And so you'll lots of times have these hypoxic regions within the tumor where blood supply is less and you're not able to get that oxygen into the tumor cells. Hypoxic meaning areas with less oxygen. So if you begin to fractionate it, you begin to slowly destroy these tumor cells and create more blood flow, and that means more oxygen, and you're reoxygenating the tumor through fractionation, which makes the tumor cells more radiation sensitive. Again, there's a really big difference between this is oxic conditions, so where the tumor has lots of oxygen, versus anoxic conditions where the tumor doesn't have much oxygen. So we want to fractionate to increase blood flow, increase oxygen, and make more oxic conditions, high oxygen levels in the tumor, and make it more radiosensitive. Again, the survival curve being here, dose here. So with a smaller amount of dose, you're able to kill a lot more oxic tumor cells than anoxic. Excuse me. Radiosensitivity. So this goes down to the cellular, tissue, and individual radiosensitivity. Individual meaning a individual human being. So cellular sensitivity of cells to radiation, tissue sensitivity. So you can think about certain cells may be less susceptible to radiation. For example, if you think about neurons, right? Neurons don't divide after a certain time in a person's life, but there are other factors that can also affect the survival rate of the actual neuron cells, and these can be supporting tissues, right? So if you start destroying vasculature, say in the tissues, in brain tissue, that too will cause the neurons to die just by a different mechanism. So tissues as a whole can be radiosensitive depending on a number of different parameters. And then there's individual radiosensitivity. And these are genetically determined for particular people and influenced by cell, tissue type, and lifestyle factors. Does anyone have any questions on the 5 R's before we go a little bit further? Okay, so we'll continue on. So we're going to get into the linear quadratic model. So this is how we quantify how many cells will die from a radiation dose. Radiobiological modeling is very complex, so we'll typically simplify this into this linear quadratic model. Again, this is not true in every single case. It is a representation of what happened, but it does give us a good idea of what's going on. So S of D, this is the number of cells surviving after a dose D. D is the radiation dose in gray. Alpha and beta represent the radiosensitivity of the cell. Okay, these two coefficients, alpha and beta. So if you can look at it, the alpha term creates an exponential decay, e to the minus alpha d. And the beta term exaggerates that decay quite a bit with this squared term on the dose. Okay, and we'll get to that in just a second. So alpha beta is the measure of the fractionation sensitivity of the cell. Higher alpha beta indicates less sensitivity to the sparing effect. Okay, we'll get to that in the next few slides. I think this will become clear. So I'll come back to this slide. So if we look at this, ignore the high LET. I just took this from a quick Google search of an alpha beta ratio. But we've got, if you look at this curve, this is a cell survival curve. And there's an initial portion, which is somewhat linear. And we've extrapolated that line into this dotted line. And then there's this sort of curve that comes down here. So if we extrapolate this line going through here, this is sort of our beta term, the second portion of the slope. And the initial linear portion of the slope is the alpha term. Okay, and so if we look at this again, here's a logarithmic plot on the left, on the y-axis, and dose on the x-axis. And so again, if we just look at the alpha term only, e to the minus alpha d, that's a purely logarithmic decay. So that would be a linear line. Okay, so we've already said we've got one linear portion here. So linear would correspond to the alpha component. And then we've got this curved portion, so we can sort of extrapolate that curved portion up for the beta term. Okay, and so if we think about cell death, there were two main areas that we talked about, the two big areas that we talked about, single strand breaks and double strand breaks. So you can sort of think about the alpha component as being single strand breaks, the beta component corresponding more, not all, but more to double strand breaks, right? And so the more dose that you have, the greater the proportion, the bigger amount of this ionizing radiation, the greater the possibility of double strand breaks. And once you have double strand breaks, cell death increases rapidly, hence this squared term. So single strand breaks, the cell is not dying quite as much. We're at lower dose, a lower probability of interaction. So it's a single strand break, linear. And then at a certain point, you start getting a high enough probability of interactions from a high enough amount of dose that you start getting more double strand breaks. And double strand breaks significantly increase the amount of cell death. Hence, we have a squared term. So that's one idea of how this alpha and beta term work. And so the alpha-beta ratio is the dose at which the beta term equals the alpha term. So the point at which sort of the single strand breaks equal the double strand breaks. This alpha and beta term are equal. So you can see this amount of beta is equal to this amount of alpha. In this case, an alpha beta of 8. So higher alpha beta indicates less sensitivity to the sparing effect of fractionation. So again, let's get to that in one more minute. So I'll show you one more slide. So here we've got two different curves, two different survival curves, one here, one here. And you can see the alpha term is here, and here you've got a really sort of rounded shoulder. This rounded shoulder corresponds to late responding tissues. So this has a low alpha beta. You can see the alpha beta terms would be equal lower. And here the alpha beta terms will be equal at a bigger dose. So this would be tumor in early responding tissues, where the alpha beta would be closer to, say, 10 gray. 10 gray falls here. And late responding tissues with this really curved shoulder, the alpha beta components become equal earlier on. Late responding tissues have an alpha beta closer to, say, 3. So let's see what happens when you fractionate it. So again, if you follow this curve with the very rounded shoulder, and if you fractionate it, then it starts over again. So the shoulder's rounded, it comes to here, you've stopped. You wait a day, you give another fraction. Or brachytherapy, you wait, a few days, you give another fraction. And then the cell survival curve starts again, that rounded shoulder, and then you stop. And then you wait a day or wait a couple of days, you give another fraction, and it happens again. And so you can see that rounded shoulder is causing it to really sort of bounce up. Whereas the tumor, where the alpha beta is really high, this alpha component is a lot more responsible than the beta component. And so fractionation, you can see, is not changing it quite as much. And so here's where we go from late responding normal tissues that would have been, if you just gave a single fraction, they would have done really poorly, right? This is survival curve. You want our late response, we want our late reacting normal tissue cells to have more survival. So they went from all the way down here to, look, the late responding ones with that really big curve, that rounded shoulder with the low alpha beta rounded shoulder, they end up going from way down here, low on the survival with fractionation, to now above tumor cells on the survival curve. That's a really important thing. So that's the main reason why we fractionate in radiation therapy, is to bring normal tissues above tumor cells in the survival curve. And this all goes back to the very beginning of that therapeutic ratio that we were talking about. We want to use fractionation and use radiation in a way that we kill tumor cells and we spare normal cells. Okay, so now we can go back and hopefully this will make a little bit more sense. So higher alpha beta indicates less sensitivity to the sparing effect of fractionation, right? That's what we just explained. Many tumors are often early responders to radiation with a high alpha beta around 10 gray. Healthy tissue is often a late responder with a low alpha beta around 3 gray. This is why fractionation is useful in tumor cell killing and sparing of healthy tissues. Some tissues that show early reactions to radiation, like skin, also have high alpha beta, which explains why many patients have skin reactions during external beam radiation therapy. And some tumors have low alpha beta, which may indicate that they could or should receive a higher dose per fraction to compensate. Okay, so really think about this graph and this graph. It should really make sense. Late responding normal tissues, tumor, and early responding tissues here, and what happens with fractionation. Does anyone have any questions on that? Okay.
I just
Well,
I have a question for my own clarification.
sure.
If the alpha beta ratio, like I forget the alpha and the beta, one is single stranded breaks and one is double stranded breaks.
Hmm.
And double stranded breaks are basically cause more significant damage. That's more difficult for the cells to recover. So it's better. Are you trying to have the ratio shift in the direction of more double stranded breaks, or you can't really control that?
The more dose that you give, the more double strand breaks you'll have. And so, what we want is actually to reduce the number of double strand breaks in normal tissues. And so, normal tissues, you can see this double strand break component is really high. And so, if we fractionate, then we can sort of reduce that effect on our normal tissues. So, in the end, it doesn't really matter too much, into the whole single strand break, double strand break. In the end, all we want to see is through fractionation that we're able to see healthy tissues have a greater survival than tumor cell tissues. That's the main component. And so this graph, I oversimplified things with just calling it single strand and double strand breaks. A lot of this has to do with repair. So the ability of the cell to repair. And so these late responding tissues are less able to repair themselves as doses being delivered. These tumor and early responding tissues have a greater chance of repair. So there's more of it than just single strand and double strand breaks. That's sort of an easy way to conceptualize it. But there's also, a lot about repair that goes into these curves. So maybe I simplified it too much, but in the end, what's important is to understand what these alpha beta ratios sort of mean in terms of what the curves look like and how that affects the two curves when you add fractionation.
Thank you. That was very helpful. And I think you're probably going to continue talking about the alpha beta ratio, but we did get a question from Abiola who said, I want to know more about the alpha beta ratio. So whatever you were going to say, just continuing on. Thank you very much.
Okay, sure. So now let's get into fractionation and HDR. So up here we've got acute effects or large alpha beta. So this would be, say, our tumor cell. And here we have small alpha beta. So these would be more like our normal tissues. And here's the HDR survival curve. So high dose rate. So you're creating lots and lots of a high proportion of ionizing radiation and free radicals in our cell, hence this really sharp survival curve for HDR compared to, for example, LDR, which allows for repair a lot more as you're delivering and not as high of a proportion of free radicals and ionizing radiation. So if you fractionate HDR, you look at two different curves. So here's more fractions and fewer fractions. So you can see the change in late effects. So these are organs at risk, late effects. Alpha beta is very small. If you fractionate, say 3 fractions, or if you increase your fractions to whatever this is, 1, 2, 3, 4, 5, 6 fractions, then you'll get a much bigger sparing. Remember, y-axis is cell survival. We want organs at risk to have higher cell survival. So fractionating HDR increases the cell survival of our organs at risk. That's a really important concept. And so lots of times, and I'll just quickly say, here's the change in acute effects for tumor cells, so large alpha beta. You can see this difference between fractionation, fewer fractions, more fractions, the effect is not as big, but more fractions in HDR makes a big change in the cell survival for organs at risk. So this is really important. So when we're talking about treatment planning, there are a number of factors that go into it, right? So one is patient throughput and machine availability and staff availability. So I know a lot of you have centers that are quite busy. I've seen that some of you have centers that treat, more than 10, even more than 15 patients per day. And that's a lot of patients to get through. And so throughput is really important to get as many patients treated as possible. So you might want to reduce the number of fractions in order to get more patients through. So 2 fractions or 3 fractions for your HDR GYN patients. However, if you have the possibility to increase it to, say, 5 fractions, this allows for a much better therapeutic ratio, right? That curve at the very beginning of the lecture about separating tumor cures from organ at risk failures. And so if you fractionate, you've still got just a small change in your tumor, but a big change in what happens to your organs at risk. So it's easier to achieve your goals if you have more fractions in HDR. But again, this is a difficult decision because there are a lot of factors that play into it, particularly patient throughput with machine and staffing availability. But something to think about and something to talk to your doctors with and to your administration about the importance of this fractionation in HDR. Okay, so
the question is the alpha beta ratio usually higher in parallel organized tissues?
That's a good question. So you've got, let's see, so I don't know if I can answer that exactly. I won't try to just say for all tissues, but I think you might be on the right track. So serial tissues like spinal cord, it's got a very low alpha beta, but lots of tissues have low alpha beta. Prostate has really low alpha beta, lungs have really low alpha beta. Tissues with a high alpha beta lots of times would be tissues that replicate often. So things like skin, that epithelium, I think I've got the right term. So that line the intestines, again, why when you deliver dose, you have lots of GI issues, typically with acute effects or large alpha beta.
You cut out for a second. You cut out for a second. You had talked about the epithelium lining the gut, and then we missed the rest.
Yep, sure. So those tissues have acute effects or large alpha beta, similar to tumor cells, because they're rapidly dividing, they're constantly dividing and renewing themselves. And so that's why, for example, you would see in pelvic patients for external beam, you'd have acute effects to the GI system because of this large alpha beta ratio of some of those cells that line the GI tract. So I don't want to just say that all of one type of tissue behaves one way and all of another type behaves another way, but you can definitely find in literature what the alpha beta ratios are for probably every, if not most, tissues in the human body. But I hope that helps. Okay, we'll move on to biologically effective dose. So this is sometimes a confusing term, BED. This is effective dose. We're not talking about any sort of equivalent dose. This is a virtual dose, this bottom line, that produces the same biological effect as physical dose with an infinitely low dose rate. So this BED does not have a lot of significance to us on a day-to-day clinical basis, nor does this BED have much significance to us on a dose that actually means something in terms of patient cure rates or toxicity to organs at risk. But what it does, it allows us to sort of make 2 different fractionation schemes equivalent through this use of BED, where we can convert 2 different fractionation to what that same biological effect would be with an infinitely low dose rate. Again, so it's not a real useful term on its own, but it's a really helpful tool, which we'll get to. Okay, and so N is the number of fractions, D is dose per fraction, little d. T, overall treatment time in days. T, delay, time for the beginning of treatments, from the beginning of treatments to the onset of rapid repopulation. Remember, we talked at the very beginning about this delay in rapid repopulation proliferation from 2 weeks to 6 weeks. And K, the daily BD equivalent of population. Okay, so there's this K term here. So this portion corresponds to your alpha beta and the radiosensitivity and repair of your cells. And this portion corresponds to proliferation of cells. So most of the time, proliferation, we're talking about tumor cells that proliferate rapidly. So after a number of days, so 2 weeks to 6 weeks, there's a total tumor time, or total treatment time, sorry, overall treatment time, minus this decay. So if you've been treating for, so if you've been treating for 3 weeks and your T delay was only 2 weeks, then you got 1 week times this K factor. This would be something in gray, which shows sort of the tumor loss, the loss of dose to the tumor through just proliferation of that tumor. And I think it will make more sense as we go further. So when to use this? It's useful in equating doses with different fractionation regimens. It's often simplified for EBRT, external beam, and high dose rate brachytherapy. So sometimes we'll simplify it and we'll just remove this proliferation term and just leave the alpha beta term. So this, when we simplify it, it assumes no cell repair during a radiation. The radiation time is in minutes, and time between fractions is long enough to enable sublethal damage repair, so 6 to 12 hours. So if you think about doing a BID treatment, 2 treatments in a day, external beam, you usually wait at least 6 hours, and that's the time for repair of the sublethal damage of cells. And we're assuming that the overall treatment time is close to or shorter than the time for the onset of repopulation. So we're assuming that the total time, T, is approximately equal to T delay. This is not always true. That's why this is a simplification. So if we solve this BED equation, and we look at different fractionation schemes, here's 1.8 gray per fraction, 2 gray per fraction, or 4.5 gray per fraction, all to about the same total physical dose, around 45 gray. If we look at an alpha beta of 10, this corresponds more to, say, your tumors, then we get a BED of these values, 53, 55, and 65. But your alpha beta of 3, which is more closely related to your normal tissues, now we get a BED of 72, 76, and 112. And now we're about to relate these to what they would mean, something more significant in clinical terms. But you can sort of see the effect of this low alpha beta being really exaggerated by high dose per fraction. It really exaggerates the dose difference of our normal tissues. So if you're using LDR brachytherapy, we would add this repair term, which we're not going to go into. It's on an Excel sheet that I have for you, but this is just an extra repair term if you're using LDR, or for example, in my treatments at my previous center where we drop below 1/10 of the original air Kerma strength of our source. We won't go into this too much detail. So biological dose, effective dose, BED, is not the same as biological equivalent dose. So a more practical approach is to convert BED values to equivalent doses delivered in 2 gray fractions. This would be our Eqd2, equivalent dose in 2 gray. The total dose in 2 gray fractions that would kill the same number of cells, given an indication of tumor control and normal tissue complication risks based on equivalent standardized dose per fraction. So 2 gray per fraction is a lot more familiar to clinicians. There's lots of data. There's lots of historical data on what happens with 2 gray per fractions. So lots of times that's what's helpful for a doctor. If we've got some odd fractionation scheme, or we're providing external beam with high dose per fraction brachytherapy, well, what does that mean for the doctor in terms of historical doses in 2 gray per fraction? We're going to see how we can go from BED to 2 gray per fraction. So you remember our BED equation right here, where ND is total dose, number of fractions times dose per fraction, total dose. And this 1 plus dose per fraction over alpha beta is called the relative effectiveness. So EQD2, equivalent dose in 2 gray, equals BED divided by this term. And so that becomes BED divided 1 plus 2 over alpha beta. So this 2 is your dose per fraction. And if we want to do it in equivalent dose in 2 gray per fraction, this just becomes a 2 gray. So it's really simple where you can equate BEDs right? So it's basically a BED for one fractionation. Then you calculate a BED for equivalent dose in 2 gray per fraction and solve for the variables. And you're left with this. Eqd2, equivalent dose in 2 gray, this total N times D, the total equivalent dose in 2 gray, equals BED divided by 1 plus 2 over alpha beta. Again, just simply taking BED for one fractionation and then saying BED for 2 gray, which you just substitute 2 gray here and 2 gray times number of fractions, total dose, EQD2, equals the other BED and solve for variables. Quite easy. So here it is again. So for tumors in early reacting tissues, where alpha beta equals 10, EQD2 for alpha beta of 10 is BED divided by 1.2. And for late reacting tissues, most normal tissues, where alpha beta can be assumed to be about 3 gray, you get EQD2 for an alpha beta of 3 is BED divided by 1.67. And so now remember this from earlier. Here was our BED for normal tissues for the same fractionation scheme. Here's our BED for tumor tissues here. But what is it in some meaningful terms? So what's the EQD2, the equivalent dose in 2 gray per fraction for our tumor is here. Our equivalent dose in 2 gray per fraction for our organs at risk is here. So you can see that with fractionation, our therapeutic ratio improves. Here's our dose to tumor. This is all for about 45 gray total dose, but our therapeutic ratio from fractionation or tumor actually does better than our organs at risk. More dose to the tumor than our organs at risk in equivalent doses of 2 gray. But if we do hypofractionation, large dose per fraction for fewer fractions, now all of a sudden our tumor has less dose in equivalent dose per 2 gray than our organs at risk. And this all goes back to those decay curves and fractionation. So this is the concept of equivalent dose in 2 gray. So when do you use this? When trying to determine whether dose to organs at risk or total dose of tumor are within known tolerances, or when combining 2 different fractionation schemes. So for example, again, external beam and brachytherapy. So again, here's external beam, 25 times 1.8 to 45 gray. This is 45 gray equivalent dose in 2 gray per fraction for the tumor, alpha beta of 10. And the brachytherapy, if you did a fractionation of 3 times 8 gray, it's a total dose of 24 gray, but equivalent dose in 2 gray per fraction, because we gave such large doses in each fraction, is actually about 36 gray equivalent dose in 2 gray per fraction for an alpha beta of 10. So our total tumor dose is about 80 gray. Whereas if you do the same thing for alpha beta of 3 for normal tissues for the same dose delivered, right here we've got 5.6 gray per fraction given, you get a different dose. So that's where we'll use this equivalent dose in 2 gray per fraction. And what's used in our Embrace 2 protocol as well as American Brachytherapy Society, ABS. So assumptions, again, remember we're assuming no cell repair during external beam or HDR, and the time between fractions is long enough to enable full sublethal damage of repair, a minimum of 6 to 12 hours. The overall treatment time is shorter than the time for onset of repopulation proliferation. All volumes for HDR brachytherapy receive full EBRT doses. In fractionated treatments, the volumes represent the same anatomical position throughout the entire treatment. Again, these are just assumptions that we typically use. And the same absorbed dose and time dose pattern for EBRT and HDR produce the same biological effect. Again, another assumption because of the heterogeneity of the dose delivery from HDR brachytherapy. So EQD2 in cervix brachytherapy. Let's look at how this works. So I'll show you this in more detail on an Excel sheet. So I'm going to go to that now. There's an Excel sheet that we're going to give to you, which I think is really nice. So like all of our RCC Excel sheets, you've got an instructions page. So lots of times these instructions pages are very helpful. So take a read. It can give you some helpful points. So for example, in this one, if we read this, if we start right around here, note that the tandem can move a lot within the uterus. So a tandem that is not fixed relative to the patient can easily change positions between stimulation and treatment. You got to think the uterus that the tandem is entering, that's something that a baby can fit in. So the tandem can move around quite a bit within there. So you might simulate, if you don't fix it to the table somehow. So if you have a vendor fixation device, or you could even just use a styrofoam block, tape that to the table, and then take the end of the applicator to that styrofoam block. If you don't do that, the tandem could be simulated in the patient like this. And by the time you get to the treatment, it could be tilted up like this, pointing right towards your bladder, or it could be pointing down right towards your rectum. So make sure that it's fixed. More tips in here. Note that various methods can be used to lower high organ at risk doses. Examples include, to lower high organ at risk doses, filling the bladder with a catheter to reduce small bowel dose, reduce bladder filling with a catheter to reduce bladder dose, utilizing needles, adjusting tandem position within the uterus to deliver dose to the CTVHR, and spare close OARs, increasing packing towards the rectum to reduce rectal doses, increasing the number of delivered fractions. Remember, the more fractions we deliver, the better it is for organs at risk. So if you started with 3, but you're going to have a really hard time achieving constraints, maybe increase 2 more fractions for that patient. So these lots of times have helpful hints. The changes tab, which tells you what to change. Here's a data tab. So you fill out this for your institution, whatever your equipment is, whatever your physicist names or radiation oncologist names, so forth. And this will propagate through the rest of the Excel sheet. Here's basically the doctor tab, which tells information about the patient. So the most important thing is here, dose per fraction, because this will be a helpful tool for later on. You can fill out the dose per fraction and the number of fractions. So we'll start with 4, and maybe we'll change it to 5 later. You'll see where this impacts something else. Here are volumes of your contoured targets. If you're contouring targets, again, you want to see either the target's volume should be about the same size, if not decreasing over fractions as the tumor is shrinking. If you see the doctor contour something one day and all of a sudden it's 25% bigger the next day, that's an indication that maybe there's something not quite right with the contouring by the physician. So I've got a plan A and a plan optimized. So if you're doing plan A, would be our historical pear-shaped plan. If you have the luxury to provide optimization, say through the use of interstitial needles, then you would also fill out this optimized plan. And it's a good way to compare, well, historically, what are you getting relative to optimizing, how are we doing as a clinic? And I'll show you another Excel sheet where you'll put data in and see exactly how you're doing going from historical pear-shape to optimize. So again, everywhere in blue you can fill out, pink you cannot. So this page is all automatically done for you, for example. So you'll just fill this out. So each fraction, you put a date, the track, the error kerma strength of the current source, and you fill out the actual doses at these points. So at some point, I'll give you a new spreadsheet, which will also have D.1 cc's. Right now, I just have D2 cc, but we'll get you another spreadsheet so you'll have a little bit more data. It just takes a lot of time to review these really big Excel sheets. So you'll fill out the actual doses delivered, and then this will tell you what the equivalent dose is in 2 gray, and it'll sum it. So here's the sum of it. Here's the individual equivalent dose in 2 gray for targets and for organs at risk, and here's the total sum, again, based on your input of external beam. Here we're saying we deliver 45 and 1.8 gray per fraction. It'll change your EQD2, for example, if we delivered 50.4 in 28 fractions. It'll change what's being calculated here. And then you'll do the same thing for the optimized plan if you have the ability to optimize your treatments. And again, it will tell you exactly what the equivalent doses are in 2 gray per fraction, as well as what it is for the total brachytherapy plus external beam. Put one note, I've locked this cell, so you can't change it. Maybe I haven't locked it yet. I thought I locked it. Okay, yes, I did lock it. So this, do you want to account for the repair half-life of cells? This we don't typically use, but I do have the equation in here. If you select this as yes, you'd have to unlock this cell, then select yes to use it, because I don't want it used very often, but only if you've got a really, really low source strength. And so that would be, far less than your brachytherapy 12 gray per hour. So you'd want to be less than, say, 10% of your original air current strength before you'd want to start accounting for the repair of the cells. So that's what this is. On this condensed summary page, it's really nice. It shows you the plan A, so historical plan, and if you have the ability to optimize, it'll show it here, all summarized. Green means passing for Embrace2. Yellow means intermediate, and red means failing. So you want to end up being all red. This is a really cool, helpful tool here. So based on what you put in here, so if I put in, say, 3 fractions, so I've already delivered 3 fractions, sorry, so let me go back. So if I put this as 4 fractions, 7 gray times 4, for example, go to my summary page. So I have 1 more fraction to go. So this tells me, in order to reach ideal Embrace2 constraints for this patient, these are the doses that would have to be delivered to the targets and to organs at risk below these doses for organs at risk in order to reach ideal constraints for Embrace2. Above this, and these are not equivalent doses in 2 gray per fraction, these are physical doses delivered. And then once these are converted to EQD2, this would allow us to reach ideal constraints. And this is the section for intermediate constraints. So if I reach these, you can do intermediate constraints. So again, these are just made up doses, just putting into check the Excel sheet, but it's really helpful for you as you're planning. So as you're planning, you've done 3 fractions, and let's say you want to deliver 2 more fractions. Sorry, this. So we'll go to 5 fractions, and now this changes. So now these doses are different than if we only had 1 fraction left. Now we have 2 fractions left. So as I'm planning, I know, okay, for my bladder, I need to keep it below 5.7 for the next 2 fractions, physical dose. And then by the time it's applied to EQD2, I will have achieved ideal constraints for Embrace2. It's a really helpful tool. And on this side, it's just a summary of targets. Red is historical plan, green is optimized, and organs at risk on this side, and then track. And so what you'll end up seeing on real patients is that typically your targets go up, your organs at risk go down, your green, and your track decreases. So you'll find that by your track decreasing just means that you've utilized radiation more efficiently. Your dose delivery is more conformal. So really helpful tool for you. Here's some Eqd2 limits. So 3 fractions, 4 fractions, 5 fractions. These are physical doses delivered, not EQD2 doses, physical doses based on an external beam of 45 gray or 50.4 gray. So again, a helpful tool as you're planning and optimizing. I'll show you one more document that I will give you all. Okay, again, this document, you would just list your patients. It's all drop-down menus again. And what happens is you will just input your data here, your finalized summary data of EQD2 for your plan A and your optimized. So each time you finish a patient, you just type that in, pretty quick and easy, and it creates all these plots for you. So these are really cool. So this is, for example, bladder. This is plan A, historical versus optimized. So the x-axis is dose to the tumor. The y-axis is dose to organ at risk. And I've done the ideal constraint being the cutoff. So for example, bladder, it's 80 gray EQD2 from Embrace2. And so what you want is all your points to be in this bottom right quadrant. That would signify you've gone beyond your desired tumor dose and gone below your desired organ at risk dose. So you can see from historical to optimized with needles, We're all down here in the bottom right. And this is our intermediate constraint. So every single one of our patients is below intermediate and getting our tumor dose. Again, here's for sigmoid and small bowel. Scatter plot doesn't look very good. That's typically your pear shape for all patients. And if you optimize, it looks really good. Ideal and intermediate is somewhere right around 75. You'll see sigmoid is always the toughest one. And then same thing with rectum. So really good tool. And this should be a nice picture representation of why it's so important if you had the possibility to do optimization, especially if you have the possibility to pursue interstitial needles, you really can get a great patient benefit. Does anyone have any questions on either of those Excel sheets? We'll be happy to help you along the way once you implement this in the clinic as well.
We do have a great question from Ayabosa. Ayabosa mentioned that they were accidentally kicked out of the call a few times, so this may have already been addressed. But question is, I am wondering how relevant the BED formula is in brachytherapy for compensating for delayed treatments, considering that the doses are high, the treatment is localized, and the time between fractions are long. Have you had to use the equation for treatment gap compensation as we do in EBRT?
That is a great question, really good question. And so that is complicated. And so Embrace 2 tells you to complete the entire course, external beam and brachytherapy, in less than 8 weeks. So if you can do it in 7 weeks or 8 weeks, then you're good. But if you go beyond 8 weeks, now this gap in treatment is significant. And so you're basically, each week that you lose in HDR, you're losing about 5 gray off of your total equivalent dose for that patient. And so you would need to account for that somehow. And that again comes from the cervix. Tumors are typically rapidly progressing. And so you start losing dose through that formula. And we'll get to that in a second, but really good question. So you really want to stay within 7 or 8 weeks for HDR and external beam. If you go beyond that, you're really losing dose in your total equivalent dose due to the proliferation of cervical cancer cells. Really good question. And again, that's about 5 gray per week beyond the 8 weeks. Great question. Okay, so I think I'm getting close to the end. I know I'm going a little over in time. Apologies. So let me try and get through the rest of this pretty quickly. So here we get into the missed doses and missed fractionation. Again, this is important for external beam and brachytherapy. So I'll go quickly and overall, how do you approach it? And then we'll get into a little bit more details. So you want to keep the overall treatment time by treating on weekends. That's one way. So if someone's missed a week of treatment, you can treat on weekends and maintain the overall treatment time. This may not be feasible with departmental resources. You could keep the overall treatment time the same by treating twice per day as needed. So again, this maintains the overall treatment time, dose per fraction, and number of fractions, but could possibly increase in normal tissue complications if too many bi-daily fractions are needed. So if you've missed a fraction, or if you missed, say, a week of treatments early on for cervical cancer, don't do BID every day the next week. Maybe do BID once a week for the subsequent 4 weeks so that you have greater chance of repair, but keep your overall treatment time. Another method is you can keep your overall treatment time by increasing dose per fraction. This maintains overall treatment time with reduced number of fractions, but not suitable for high dose per fraction treatments, linear hypofractionating.
Sorry, could you repeat the last thing again? Because you cut out just for like 5 seconds.
Sure. So if you keep the overall treatment time by increasing the dose per fraction, this is good for the tumor, but it's bad for normal tissues, where these late effects, you'll have a big increase from the hypofractionation. So you have to really be careful if you try to keep the overall treatment time to destroy the tumor and not let it proliferate, but then you have to watch out for your normal tissues from the hypofractionation. Or you could deliver extra fractions with increased dose per fraction at the end of treatment. This allows for partial radiobiological compensation, but still every additional fraction you add just adds dose to your organs at risk. So you have to be careful. So again, recall these equations. So here's your alpha beta term about radiosensitivity, repair, all that good stuff. Here's your repopulation term. Again, the time of delay before the onset of rapid proliferation, repopulation of tumor cells. Here's your overall treatment time. And here's the dose per fraction that you're really losing after this onset of rapid repopulation. So K is the daily BED equivalent of repopulation in gray per day. So here's a quick curve that just shows total dose required for a given tumor control probability. So if you give, here's dose, total dose required on the y-axis, again, for a given tumor control probability. And here's the time on the x-axis. So here's the point of rapid proliferation, this T delay, then at that point, your tumor starts rapidly proliferating. So in order to maintain the same tumor control probability, after more time, you have to increase the amount of dose significantly to account for this inflection point where proliferation really starts to happen. I left one page out, but your T delay is about 28 days for head and neck. On average, for cervical cancer, literature goes anywhere from 14 days to 28 days. Again, just for your information, this is mostly for using this equation to do calculations. So I'm not going to go through too many details of these calculations. I'm going to provide a document which goes through explicitly 6 different examples of how to calculate adding fractions, increasing fractionation, hypofractionating. It goes through in-depth 6 different examples. It's a really good paper. So I won't spend too much time right now, especially since I'm sort of over time as we speak. But it just shows you how to use this equation with the different T delay and the K factors, which in the K factors could be anywhere from 0.5 gray per day up to 0.9 gray per day for cervical cancer. It's usually considered about 0.9 gray per day for head and necks. And then for less rapidly proliferating tumors like breast, it's on the order of 0.3 gray per day after the time delay, and prostate maybe 0.1 gray per day after the time. But this equation will be used. Again, I'll give you the handout and we'll go explicitly on how to use this. Here's another example. BED is 4.9 gray less than prescribed. Can we just increase the dose per fraction to compensate? So if you use that equation, you would need to hypofractionate to increase the dose per fraction for the last 5 fractions. But again, this would adversely affect organs at risk. Again, I won't spend too much time on these details. I'll give you explicit examples that you can go over in a really good paper. Another example, you lost the 7th week. How would you account for this? Again, I'll let you go over these examples. If you have questions, you can let me know. It's difficult when you start really changing fractionation schemes and high dose rate brachytherapy at such high doses per fraction. And like one of our participants asked, length of time between fractions, but still it does hold that you want to stay within 7 or 8 weeks, according to ABS, American Brachytherapy Society, and Embrace2, the international group. And any additional week corresponds to about a 5 gray loss in equivalent dose per 2 gray. Again, caution, these calculations should only be used as guidance, not as an absolute rule for clinical decision-making. So you would present these to your doctor, but in the end, they're guidance and they're not an exact science on exactly every tumor and every fractionation scheme. They're used as guidance. Ultimately, your doctor will make decisions on how the patient is doing. A cautious attitude is recommended for the health and safety of our patients. And here are some references.